Hey everybody, it's Angie and welcome to Hot and Flashy. You guys, I feel like I have not sat in the recording chair here at home in a dog's age. As most of you know, I went to a creator house in Austin, Texas a few weeks ago, and while I was there, we had the honor and the pleasure of having Dr. Mary Claire Haver join us. Dr. Haver is a menopause expert. She's a board certified OBGYN. She's also been certified by the Menopause Society, and she's also a certified culinary medicine specialist. She's the author of 2 books. One is The Galveston Diet. The other one just came out 2 days ago. I've got my copy here. It's called The New Menopause. She has over 3 million followers on social media, and she really is the doctor that's leading the change in the conversation in menopause and menopause health and menopause treatment today. And so we were just so happy that she could take time out of her very busy schedule to come and join us at the Creator House. This video is chock full of such important information for women going through the menopause transition, for women who are postmenopausal. The other 3 creators on the panel with me are Penny Smith from Penn Smith Skincare and also Justin and Deanna Hickox. Justin has a hair care channel and Deanna is active on social media as well. Being at the Creator House was a little bit of a challenge in that our filming space was not ideal. We thought that this room was enclosed, but it turns out it's a screen porch. And so you could hear noises from the outside. So at one point there was a dog barking, a plane going overhead, the lawn guys arrived, it was windy, there were birds chirping, which is lovely, a FedEx man came. You know, everything happened during the 2 hours that we had Dr. Haver there. So I have scrubbed the sound to get rid of all the background noise. There is still a little bit of it in there. If the sound isn't perfect, my apologies. It's not what's important in this video. What's important in this video is the information that Dr. Haver brings to the table. She is such a wealth of knowledge. And so let's get started with the interview. We just wanted to define like what is menopause for the people who don't know that it's, you know, is it an event? Is it a...
Going back, yeah, menopause medically is defined the worst possible way. Right. 1 year without a period. And what if you don't have periods?
Right.
You know, like you don't get a definition. Let's do some endocrinology so that you guys followers understand this. We're born with all of our eggs. Most people don't realize that. You know, the Justins of the world get to make their stuff fresh every day. Your germ cells.
I didn't know this. I learned this from you. I didn't know it.
So when we're inside of our mom's tummies, we have the most eggs we'll ever have, 4 to 5 million. By the time we're born, we're down to 1 to 2 million. Because they are constantly deteriorating over time. By the time we're 30, we're down to average of 10%. So about 120,000. And by the time we're 40, we're down to 3% of our egg supply. So every month when we're in normal, healthy reproductive cycles, we have this kind of EKG looking estrogen surges, then our progesterone surges, all driven by hormones from the brain. So the hypothalamus in our brain is constantly sensing for estrogen our whole lives, whether we're menopausal or not. And when the estrogen levels are low, it sends a signal to the pituitary saying, make more. The pituitary goes, all right, ovary, you're up. Let's go. And starts doing LH and FSH pulses to the ovary. The ovary's like, I got you, coach. All right. Starts recruiting these little germ cells to try to ovulate. And that's where the estrogen and progesterone production comes from. Well, we develop resistance, like insulin resistance. We develop LH and FSH resistance because the ovaries are aging twice as fast as any other organ in the female body. And it can't do the same thing. So the brain's like, hey, I'm not seeing my usual estrogen surge. Pituitary, what's going on? He's like, all right, I'll just like send more hormone stimulation down. And so you end up with these giant surges, and then the ovary just explodes an egg all of a sudden, a little bit late sometimes, much higher estrogen levels. Then we get these deeper falls. And then the progesterone takes forever to catch up. And so instead of this nice EKG, you end up with these chaotic cycles that are no longer predictable. And all the ensuing, besides what's happening with our periods, every other organ system in our body gets hit.
I was going to say the evidence of it is that your periods go crazy.
Yeah.
during
That's the
menopause.
easy part of it.
That's kind of one of the first triggers that you know.
Yeah. So that's one of the easiest recognizable causes. But anxiety, depression, frozen shoulder, you know,
sleep
disruption, what's happening here in my midsection, which is why my patients come. And, you know, like I've done nothing different. I've changed, you know, what I was taught to say in my training was work out more, eat less.
Right. Yeah.
And I said that for 20 years and I'm so sorry. So what it represents is that you have run out of eggs. Every day after that point, you are postmenopausal until you die. So we should not define menopause by the presence or absence of symptoms for a postmenopausal patient, because your genital urinary system will 100% be affected every day of your life after menopause. Your bones, your muscles, your musculoskeletal system will be affected. And so it is so important to realize, like, you have to protect those systems or they're not going to protect you as you age.
I was the person that I thought, okay, perimenopause, menopause is hot flashes and it's no periods. And so I did have frozen shoulder in both my arms. What are like other common symptoms that people might just like balk at and think it's something else?
So the ones that when I talk about that blow up the internet are ringing in the ears, so tinnitus. Whenever I talk about that and the connection to menopause, people go crazy.
Yeah.
The other palpitations. Palpitations are a form of vasomotor symptoms. So hot flashes, like palpitations are a form of a hot flash.
Oh.
And that people, they're like, wait, what?
Yeah.
Wait, I had $1 million cardiac workup. Wait, like I wore a Holter monitor for a month. I'm like, well, not to say you didn't deserve a cardiologist to peek in on things, but you probably could have just started a little HRT and see if they got better. Like that is how common they are. So musculoskeletal syndrome of menopause, including frozen shoulder. Joint pain with no injury.
Yes. Yeah.
80% of women will have it. And for 20% of us, it is your worst, most debilitating symptom. For some, debilitating.
Wow.
Yeah.
So 80% of us have brain fog. Like our whole brain rewires
Yeah.
through the menopause
No
transition.
kidding, yes.
Right.
So yeah.
So speaking of the symptoms, I'm going to have to plug your new book
Oh.
because there is a whole entire section in here called the Menopause Toolkit. And I marked it off because it is literally like this much. I have the paper copy, but
It's like a third of the book.
it is huge. And all of these symptoms, I would love to hear you just tell us about the Menopause Toolkit, because to me, that could have been this book. That is such a valuable resource for women to have that. And I'd love for you to explain what it is.
So when my patients come to me and are like, we're trying to map out, their best life for the next 30 years. And first thing we attack is their symptoms, like the acute problems. And then we're going to talk about how to protect your health long term. But what I've learned through this whole menopause journey and research and my friends and the menopause is that every organ system in our body is affected by the loss of estrogen and progesterone and testosterone. And that may look like, I counted 75, 76 different symptoms throughout each organ system. So I wanted to address each of those individually. I tore through the literature to see what we know, what we know hormones help with, what other pharmacology might be available, what lifestyle changes might be affected. Because this is the thing that most women are walking to their doctor's office and they're like, oh, I don't know what it is, just part of your life,
Part of getting old.
Yeah. And so I just wanted a toolkit for people to use. Now, some of them are robust and you have multiple things that you can do, but some we're just now learning about the association with estrogen loss and we need more research. So,
Oh, and I think just the fact that they're listed will be helpful.
well,
for
I
people.
wanted to validate people because so many of us are walking out of these appointments because the healthcare providers don't know. And, the clinicians have no idea that any of this could be related to menopause. And we just need so much more education.
Okay, I'm going to read a passage from your book, and I really would love to ask you about it. You say that at age 48, that you and your healthcare provider decided to stop taking the pill to see where you were hormonally.
Right.
And around that same time, your brother Bob got ill, and unfortunately, he passed away. And you started to have symptoms, and then you said you tried to power through it. So you decided to take hormones. And what I wanted to know was, how is it that an OBGYN felt that she had to power through it? And now here you are, this world-changing, amazing women's advocate, menopause expert. How did that happen?
So, that was December 2015 when I stopped birth control pills. Right at the same time, he got super sick. At the time, based on what I had been taught in medical school, which was pretty much nothing. And in residency and all of the fallout from the Women's Health Initiative, I was kind of under the impression that you only give hormone therapy if nothing else is working for the shortest amount of time, for the lowest dose possible. Otherwise, you were going to cause harm to the patient. So here I am, miserable, suffering miserably. And I kind of treated it like I treated my epidural, in labor where I was like, well, let me just see how it goes, and I'll see if I can tough it out. And of course, I got an epidural at 3 centimeters because it was not happening. It was not going to happen without one. And I look back on that time and I really felt like I was throwing in the towel. I was a little bit of a failure because I wasn't strong enough to tough it out. And since that time, everything that I've learned about the benefits of hormone replacement therapy, it's more than just hot flashes, that it's actually protecting my brain and my cardiovascular system and my bones and my general urinary system and all the other organs in my body. So it did take years of self-reflection, research, meeting other menopause providers, real experts in this space, to realize that for me, thank goodness that I was able to start at a time where I could reap the most long-term benefits, and I didn't hold out for longer, which would have actually harmed me in the long run.
And I feel like your story mimics almost everyone's story who went through it at the same time, because I was the same way. I had gone off birth control because I thought estrogen was evil, and then kind of came around when I had terrible symptoms and my life was compromised. And then I came around to the idea that maybe HRT wasn't so bad for you. Maybe it could actually help, and it was protective for those things I had heard. And so then I decided that maybe I should start it. But I feel like there's that whole generation of women who are caught in the same thing that we were.
It's like you feel so alone in like this transition, and you're like, what is going on? But you keep it to yourself, right? But then when you share, oh my gosh, I've been feeling like this, and then people are like, oh, me too.
Yes.
Me too. Oh my gosh. And then you don't feel so alone.
That's
anymore.
the beauty of social media. Like, had I had an easy menopause, or had I not been, on social kind of finding my footing, I don't know if I'd be where I am today.
Yeah.
If I just would have breezed through it and, gotten off the pill and been like, I don't know what's going on. I just don't have periods. And, that I wouldn't have been able to build this platform and share everything and learn and have the desire to do it. And so I'm just so grateful.
Yeah, I definitely think that the tide is turning, but even at my age, it's still selective doctors that have the right information.
Yeah.
So we have an entire generation of clinicians, OBGYNs, family medicine, internal medicine, all the people who are kind of on the front line of healthcare for females who did not receive adequate training or education and have not been updated in the latest advances and the latest kind of reinterpretation of the data to know actually how beneficial and safe hormone therapy is. And it is really incumbent on us, sadly, as me as a provider and a creator to keep talking about it on social media, because your generation, our generation, is going to have to advocate for ourselves because you might know that more than your provider, and it's not their fault. They weren't taught, they have no time to keep up with the latest. And it's just the little box that menopause gets shoved into in the spectrum of women's healthcare, and that's got to change.
Yeah. Can we just go over a little history of how we got here? Because I was looking at the history of HRT and menopause the other day, and HRT at one point was the most prescribed medication or the most used medication in the United States in the early 90s.
Yeah.
And then we got to the point where there was the flush herd around the world. And now here we are today where we're trying to get people back to just a normal place where you could have a conversation about it and find out what you need. So what happened in those years?
You're right. In the late 90s, about 38 to 40% of women were on some form of hormone replacement therapy in their menopause journey. So when the Women's Health Initiative, here we go. It's the first major study done for women's health and menopause. It was $1 billion study. It was from the National Institutes of Health. This was incredible. Like, we were so excited when I was a resident to learn that finally women were going to be studied. Aging women were finally getting their due. We knew from observational studies that women who were on HRT had lower cardiovascular disease. So the question was, is that just because healthy women get HRT or wealthy women get HRT? And is that an artifact of patient selection, or is this a real benefit? So in order to do that, you need a randomized controlled study. So they recruit tens of thousands of women in each arm. So they started with an older population because we don't get heart disease until we're in our 60s and 70s. So the average age of the WHI study was 63. Remember, the average age when we start menopause hormone therapy at the time was 50, 51. And so we're already 10 years into the mix. They excluded women who had hot flashes.
Wait.
Yeah.
because they would be able to tell who was on placebo or not.
Oh.
Remember, this was a randomized double-blind trial.
Well, okay,
So
that
what
makes
women will
sense.
know immediately if our hot flushes start. So we've already excluded 80% of menopausal women so that they wouldn't be unblinded. They put everyone on the meds, half on placebo, half not, divided them with, people with the uterus got Prempro or placebo versus Premarin or placebo, and they start measuring. What they found was that there was a very slight increased risk of breast cancer in the patients who were on Prempro, but not on the patients on Premarin only, on estrogen only.
Mm-hmm.
And so they immediately stopped that arm of the study. Here's the problem. They stop the study. They call a press conference at the Watergate Hotel. They don't publish the study yet. It's not available for us to read. Every major news outlet was there and said, estrogen causes breast cancer. And that was
The flush.
the flush.
Yeah.
80% of women immediately stopped their hormone therapy, threw them in the toilet, threw them in the trash, and there were almost no new prescriptions of hormone therapy starting. Then they kept the estrogen-only arm going because they actually had a decreased risk of breast cancer. We'll talk about what that risk really meant.
Yeah.
But then they found a slight increased risk of stroke. Okay. Again, biological explanations for all of this. So let's go back to the Prempro arm. So it wasn't the estrogen, because the estrogen-only arm had a 30% decreased relative risk of breast cancer. So it went from about 4 out of 1,000 women per year develop breast cancer on placebo. We get breast cancer because we have active breasts, right? To 5 out of 1,000. That is a 25% increase relative risk. The absolute risk was about 1%, 0.8%. So there's a big difference when we're talking about statistical populations versus Penn. What is your risk of breast cancer if you take this versus you don't take it?
Right.
And women weren't given the agency to say, I'll take that risk because I might have decreased risk of cardiovascular disease. For the next 20 years, the only conversations around women's health were centered around the risk of breast cancer. No discussion of cardiovascular disease, osteoporosis. Those are just old lady diseases and you're going to get them. There's nothing you can do. The risks were dramatically overestimated and the benefits were never discussed. Decreased risk of colon cancer, decreased risk of osteoporotic fracture, all the things we knew already, decreased risk of genital urinary syndrome, decreased risk of UTIs and urosepsis and hospitalizations in elderly patients. Not giving patient informed consent and allowing her to make a judgment for herself. So then it kind of like throw out the baby with the bathwater. Anyone with a family history of breast cancer can't take estrogen because it might kill you. Anyone with a history of a blood clot or a stroke can't take, or a family history. And so all of a sudden, people are terrified of hormone therapy. I was a little bit scared of hormone therapy, like going back to my story.
Why do you think they did that? Why did they do that press conference? Why did they not say your risk goes from 4 in 1,000 to 5 in 1,000, which is a lot
still
different
alive.
than your
Ask them.
25%? Yeah. I mean, because the difference between saying 4 in 1,000 and 5 in 1,000 and 25% increased risk is huge to anybody. Like that's simple. And they knew it was 4 to 5 in 1,000.
I think it's politics. I think it is a certain mindset of I've spent all these years researching and studying this. And if I change my view, I might lose credibility amongst my, there's a lot of like academic politics involved here. And when you dig into the history of women's health and the patriarchy and misogyny, I mean, I hate to go there, but it's there. And some of those researchers to this day are digging their own graves on this data. And, even the Lancet just published this huge 4 articles. And so like the Menopause got together and, we've done massive rebuttals. And, at the end of the day, there's still people who are writing articles as experts in this field who feel like a female should accept her due and she can just outthink her menopause and everything will be fine. Why is it that when you look at funding for women's health, the overwhelming majority of the research dollars go into reproduction, getting you pregnant, keeping you pregnant, having a healthy pregnancy, important stuff. It's like 10 to 1, the spending. Why is the last third of my life
not important?
Not as important to study, to keep me healthy. Yes, we're living longer than our male counterparts. But we're living in 20% poorer health than our male counterparts. So women are twice as likely than their male age matched counterparts to end up in long-term nursing care facility for fragility. for dementia. And our lack of hormones has a lot to do with that.
Right.
Yeah.
But I remember like me reading Estrogen Matters from, Dr. Blooming and Dr. Tavris and being like, wait.
Yeah.
Why hasn't the American Board of OBGYN brought this to the forefront? Why, when I read my recertification articles every year, no one is talking about this?
Yeah.
Let's talk about the good stuff that's come out of that
Yeah, let's
study,
talk about
because
the good
there's
stuff.
some amazing data that's
Right.
come out. They continue to study these, even though they stopped the medication, they continue to gather information on these patients for
Yep.
years and years and years. And what they found is the American Heart Association, the AHA, and Circulation Magazine, they went through and fine-tooth combed the data, the raw data, and subdivided it by age. And what they found, we have now what is the healthy cell hypothesis and the timing hypothesis. So the healthy cell hypothesis basically says that estrogen supports a healthy cell, and it is better at prevention than cure. When we lose our estrogen is when we accelerate aging of our cells.
Wow.
And the timing hypothesis is that the timing of when you start hormone therapy in relation to your menopause matters.
Right.
So the women who started hormone therapy within the first 10 years of their menopause, if you get it in that 10-year window, it's protective. So you've got this 10-year window. If your cardiovascular disease has started and you have plaques and calcified plaques, we might make that worse, at least in the first year of starting hormone replacement therapy. Where the gray area is it okay if you've been menopausal for 10 years? And now, is it okay for you to start hormone therapy? Maybe. So it's a more nuanced discussion, and we need to check, do you have any plaques? So we can do calcium cardiac scores. It's a CT scan of your heart. You can do an ultrasound to measure the thickness of the intima of the carotid arteries, that lining, those cells that line, to see if you've already have some plaque buildup. So those are the things I do for my patients before I say, okay, no, absolutely not. Because if she's healthy,
Right.
we could prolong her health for longer with hormone therapy. And that data came from the WHI.
And if you go in and your doctor agrees to give you HRT and they say, I'm going to put you on the lowest dose for the shortest amount of time.
So that is
Do you
no
push
longer
back on
a
that?
thing. You absolutely push back on
Yeah.
that. You ask them why and to supply the data. The latest recommendations from the Menopause Society are, it is the dose at which symptoms are controlled, whatever that dose is, for as long as it will keep you healthy.
Right.
And that is a conversation I have every year when my patients come back. Have you developed any new medical problems? Have you developed a contraindication? If not, let's continue. I might die with an estradiol patch on.
I'm hoping to.
If you start hormone therapy in the most, therapeutic window within those 10 years, there's no age at which you must stop.
Good point.
You can continue. It's different than starting older. What they found is that in the patients over 65, and this was just published this week of this filming, they followed Medicare patients who happened to have been left on hormone therapy past the age of 65. And if they were on hormone therapy versus not, or if they had stopped it, the ones who stayed on it had lower everything. Every disease you can think of. You're just a little bit healthier with hormones than without. So heart disease, stroke, breast cancer, all of it.
Right.
So what they found though was they did better on the lower doses. So like we're all thinking eventually, like once the hot flash risk and all that declines, though 40% of women in their 60s will still have hot flashes, by the way.
Right.
Then you want to start tapering them down. You can keep them on it, but you want to go patch,
Okay.
it looks like, and then maybe taper down into their 70s and 80s if they want
Okay.
to keep going. So that'll be my plan. So I'm only 55.
Right.
So right now I'm on the highest patch, the 0.1. I'm killing it.
Yeah.
I'm awesome. I'm also on progesterone and vaginal estrogen and topical estrogen, but whatever. And testosterone. So all of my hormones are replaced in every possible way. But probably in my 60s, I will start kind of experimenting with walking down the dose of my patch.
Okay. So I'm 61 and I just increased.
That's okay.
So is that okay?
That's totally okay.
Because I don't really have like blood clot issues.
Issue,
or
yeah.
Because
that
isn't
kind of
it, she
thing.
wants to have her symptoms.
Well, she was symptomatic.
Yes.
Of course I would go up on
Right.
the patch.
Yeah.
Yeah.
And I feel like I almost missed the window of opportunity because all this information wasn't coming out when I was first going through, menopause that first year without a period. It took me 4 years and 3 doctors to get on the right HRT with the right delivery method.
I really feel fortunate to be this age at this time. Like I feel really lucky. I know I feel fortunate for you that
yeah,
you
me
weren't.
too.
But I think about the people who are maybe went through menopause 12 years ago.
Right.
Dang it, it's
Yeah.
just that's
It's not too
unacceptable.
late,
It's not too late. It's not too
What
late.
happened to them at that time is not going to be tolerated anymore.
Right,
But
right.
like, I have tons of patients in their 60s, 70s, 80s
Mhm.
and we are mapping out plans, may or may not include hormone therapy. Those are individual nuanced
Right.
discussions. But like, they don't have to break and
Right,
fall.
right,
They don't
right.
have to get dementia. Like,
Yeah.
we're going to put them on a plan
Mhm.
to decrease that risk as long as possible.
And for those women who like are older, they may have missed it or they may not. They will need to have a discussion with a good doctor, and there are no resources in their area. Where can they find
So,
educated
menopause.org.
resources?
So menopause.org has a certification program,
Okay.
the Menopause Society.
Mhm.
Look for the certified check, not
Okay.
just all the they list all of their members, but like they need to be certified.
Okay.
It's not perfect. That's one
Mhm.
place to start. I'm going to start certifying. I'm going to start teaching clinicians how to do menopause care the way I do it.
Okay.
So that's coming
That's great.
2025, or
Mhm.
actually by the end of this year, we'll have it. Also, there's some great telemedicine options
Mhm.
that are just built to take care of the menopausal patient and
Yeah.
they have trained their providers. I've vetted 3 of them. They do
Yeah.
not pay me to say any of this. I am
Mhm.
friends with them, but
Yeah. Yeah.
so MIDI
Mhm.
Health takes insurance. They're more traditional model.
Okay.
They give you a regular prescription you can take to the pharmacy.
Mhm.
Alloy Health is
Mhm.
another really good one.
Yeah.
And then Evernow is
Okay.
another.
No, I'm friends with some of them at Alloy too, and it's wonderful.
Mhm.
I mean, the care that you get. Just the other day, I switched from gel to the Eva Mist,
Mhm.
estrogen, and it was Sunday or Saturday at like 7 p.m. and I'm texting back and forth with my doctor on Alloy. I'm
Right.
sorry, but that's amazing. She's
Right.
like, "I'll make sure that gets right out. Do you have anything else?" And I'm thinking, this is incredible.
Right.
And she's
Yeah.
Menopause Society. She's, the whole
Mhm.
the whole thing.
Yeah.
So it's
And you
wonderful.
can mix and match, because I have a traditional
Mhm.
OBGYN who I found on the NAMS website, but she's not like so forward,
Right.
She has me on estrogen and an IUD for my progesterone, but has never talked about testosterone, has never talked about.
And she wasn't trained. I mean,
Right.
I was doing HRT and no testosterone. I was terrified of it
Right,
until
right.
I met Kelly Hasperson
Yeah.
and Rachel Rubin,
Yes.
who were like,
Yeah.
girl, sit down.
Yeah.
Yeah.
And I
You know,
complain
we need to
about how I
talk.
still can't sleep, and she really isn't offering me oral progesterone. And so I'm thinking I might just, so what I get from her is what I get from her. And
You can,
I only
like,
see her once a year,
upgrade.
but I could go to a
Yes.
telemedicine as well
Yeah.
and
Yeah.
get a few other things mixed in. Like I really want to start the face estrogen and
Mhm.
the other estrogen.
Right.
Just, like add some things
Yeah.
on and see how it goes. So let's say we have an example of an older woman who's say 68 and she's in good health and she works out and everything, and she can't take estrogen for whatever, or like just
She doesn't want to.
She comes into your office, she doesn't want to,
Mhm.
or she's not a good candidate. What can she do to be the healthiest person if she's completely missed the window?
So I would have a discussion with testosterone with her and its benefits.
Okay.
We know that for sure it's going to help with desire. So if she
Yeah.
has any issues with HSDD and medicine or decreased
Mhm.
libido, and we've ruled out other causes, so she's not having pain, we're going to talk
Yeah.
about that. I'm going to talk to her about vaginal estrogen because it's a whole different discussion because it can be preventative for UTIs and the health of the genital urinary system.
Right.
And so all the estrogen we're talking about here is systemic estrogen. That's treating your brains, your
Right.
bones, everything, right? Vaginal estrogen is treating the vagina, the bladder, the vulva. It's local, the same as like putting it on my skin. I do use estrogen on my face. And so the local therapy is not systemically absorbed into, and it's been tested multiple times in any clinical situation. So vaginal estrogen has no contraindications.
Mhm.
If you have a vagina, you can use it regardless of what's going on in your body elsewhere.
Right.
And so you have blood clots, you have breast cancer, you absolutely can use vaginal estrogen. So I want to be clear about
Right.
that.
And what symptoms would that help with?
So genital urinary, very long.
Explain what that is.
So let's go through history. In the 50s and 60s, they called it senile vagina.
Oh gosh.
Wow. What?
How did
Senile
vagina?
vagina. Senile
Right.
vagina. Yeah.
Okay.
So when we lose estrogen, the tissues of our bladder, the bladder neck, the urethra, which is the tube that drains our bladder out to the world, and the vulva, like everything from like the hip bones down is highly estrogenized. And when we lose our estrogen, those tissues become way less resilient. So we lose elasticity, we lose mucus production, we lose thickness, we lose resilience to infection. It's just awful. So the number one treatment that works for recurrent UTIs in a menopausal patient is vaginal estrogen, not recurrent antibiotics.
Wow.
And if you're not being offered vaginal estrogen, that should be malpractice, because we can decrease the rate of hospital admissions for urosepsis and UTIs by 50% if all women just use vaginal estrogen prophylactically after menopause. So all of those tissues. So if you're having uncomfortable intercourse, and when you didn't before, and this is new, stop suffering, stop relying on just lubricants. You need vaginal estrogen stat. So there's a black box warning on vaginal estrogen that says it causes blood clots and bring it, because they're using the same warnings from the WHI, because the Food and Drug Administration. So the first fight is to get the black box warning taken off of vaginal estrogen.
So it's safe for people who have had breast cancer or have a history of breast cancer in their family to use vaginal estrogen.
Absolutely.
For all those symptoms.
Another thing, talking about sexual health, is that we see, and a lot of people don't talk about it, but we see delayed orgasms and less intensity or just loss. And we're thinking that the vaginal estrogen can go a long way to help with that as well. I'm also going to do a deep dive nutrition, movement, talk to her about osteoporosis prevention. We're going to get a bone density. I'm going to do her body scan, look at her visceral fat, and we're going to have very focused conversations around her body composition.
Okay. And then is it going to be more lifestyle changes? Are there other medications that can help? Like, if you can't take estrogen, but you are osteopenic.
Yes.
There are other medications.
So there's the Proleas, there are the bone resorption. So the reason why we have osteoporosis is we are constantly remodeling our bones. This is healthy. That's why a broken bone will heal. You don't have the same bones you had 10 years ago, 5 years ago, because we're always chewing up bone and laying down new bone.
Right.
And the resorption, the chewing up part, gets a little faster, and the laying down part gets a little slower when we lose estrogen and the sex hormones change. So that combined with, we tend to slow down and we don't lift as heavy, and those things all stimulate bone growth. So the aging process is part of it, but menopause accelerates it.
Right.
And so the medications outside of estrogen, which is the most effective preventative thing that we can do, is stay on HRT for our bones, are the ones that decrease resorption. So that's going to be your Fosamax and Prolia, but they're very expensive. Fosamax is very hard to take.
Do they have a ton of side effects? Because I had
a ton of gastrointestinal side effects.
My audience was like, "Do not go on that." I mentioned it in passing.
You lose teeth. Like the dentist
my mom
hate
did
it.
Prolia, and they did not really hammer home what it meant for her teeth. And so now she's 77
as well.
Yeah, it does. It just messes with your teeth. And so now she's gone in, she's lost, she's got a great mouth of teeth. She's going to be 78, but there's no implant she can do anymore. Because it ruined her for the rest, which is crazy,
right?
And
so patients aren't getting great counseling about that.
So preventative again is really
prevention is key.
Are there any more holistic or supplementation or anything?
So when you look at the studies for bone loss, they basically take people with osteoporosis and see what makes that better, because we can measure those bone densities. One, I think every woman should just pay out of pocket at 45, 50 and go have a bone density done. Most women are not diagnosed with osteoporosis until they fracture.
Right.
Oh, wow.
And they're not screening until 65, which in my opinion is way too late.
Right.
Do not wait for your insurance to catch up with that. That is one investment you should make in yourself. So weight-bearing exercise, again, the musculoskeletal unit works together. Strong muscles equals strong bones.
Right.
It's actually rare for the obese patient to have serious osteopenia, osteoporosis. It's usually thinner patients. Why? Because they get up every day and put on an 80, 100 pound, 50 pound weighted blanket to go do life.
Right.
Yeah.
And so their muscles are working harder. It's rare that I have a patient who is obese with a muscle issue, with low muscle mass, because they have to work harder to go to the bathroom, go to the grocery store, go to work. Right. And so as the weight's coming off, I'm talking to them. I'm like, okay, get a weighted vest. There's studies done in nursing home and in long-term care facilities looking at bringing these women into the gym and doing deadlifts and squats, and they're killing it and their bones are stronger. You can always grow stronger muscles and bones. It's just harder. And so adequate protein intake, key. Right. Remember that I start my patients at 1.5 and I go up from there for protein recommendations. Avoiding the simple sugars, making sure that you're doing at least 2 to 3 days a week of resistance training, progressive load, getting stronger and stronger. cutting back on some of the cardio and substituting in the resistance training. The collagen studies look pretty good. They're small. We need more, but I'm recommending collagen to my patients. There's a specific bioactive collagen called Fortibone. It's in one of my products, full disclosure. And it has been shown to help with improving bone strength.
What about other supplements? Because, your doctor will say, well, make sure you're taking enough vitamin D and calcium.
Okay.
And that's all you ever hear.
Neither vitamin D supplementation nor calcium supplements have been shown to improve bone density. However, the people who are deficient in these two have weaker bones and weaker muscles.
All right.
So calcium in its natural form in food is way better option for you.
Okay.
So what I tell my patients is we're not doing a calcium supplement. You need to find the foods that are going to allow you to get the right amount of calcium per day. And if you absolutely can't, then we'll supplement only that little tiny bit. Because what they found was that calcium supplements lead to kidney stones and they lead to increasing rates of plaque calcification.
Right.
So you're way better off just getting it from
It flows
food.
around in your blood and it gets caught in your arteries. Right?
So it calcifies the plaques. The other thing is like when I talk about protein and frailty, women who ate higher amounts of protein in their diet, if they had 1.3, so the FDA recommends 0.8, most women are getting 0.6 in the US, grams of protein per kilogram of lean body weight. So lean meaning your healthy body weight, and most of you all know what your healthy body weight is. I don't need to tell you. There's no calculator you need for that. So you look at that and you say, okay, the women who ate more protein had lower fragility scores just based on protein intake. And if you push that 1.3 to 1.6 to 1.7, you did way better with osteoporosis and sarcopenia.
Oh, wow.
And so just by protein, and that all came from the WHI. So there's a lot of good data that came from this. Staying healthy longer is not just about hormone therapy. It is literally the toolbox, all of the things.
Absolutely.
So
All the lifestyle choices. We didn't really touch hugely on breast cancer. So, because like 90% of the questions that I got were on breast cancer. If you've had breast cancer and if there is a history of breast cancer in your family.
Okay, those are two totally separate things.
Okay, so let's start with if you've had breast cancer, what are your options?
It depends on your stage, your type. You can very much not increase your risk of recurrence after treatment with hormone therapy.
Okay.
That is possible. They're all told, no, you can never have estrogen. Here's the thing. Estrogen doesn't take a healthy cell and make it malignant. We all start with healthy breast cells and then we actually get cancer every day. We get cancer somewhere in our body probably every day, and our immune system immediately recognizes that cell as foreign and kills it. Okay. What happens when we get cancer is you've lost the ability to attack that cancer cell, or you have a tumor promoting cell, which promotes the malignant transformation of a healthy cell. Okay. So the highest our estrogen levels ever are in our lives are in pregnancy. And they stay that way for 9 months.
Right.
And it's very rare to get a breast cancer in pregnancy. The most likely time you're going to get breast cancer is when you're postmenopausal, when you don't have any estrogen naturally in your body.
So
Women who are diagnosed with breast cancer on HRT have lower stage and higher survival rates than women not on HRT.
The stat that really got me was that the number one killer of women is heart disease.
Cardiovascular disease.
Right? It's going to kill far more women than almost everything else combined.
Yes.
Right?
Yeah.
So we're all kind of afraid of hormones because the thought was it's going to give us breast cancer, but which it doesn't. And even if you get breast cancer, you still are more likely to die of heart disease than of your breast cancer.
Right.
And I'm not trying to minimize breast cancer.
No.
Anyway.
So the one of the biggest risk factors for breast cancer is alcohol consumption. So if you're really serious about decreasing your risk of breast cancer, stop drinking alcohol.
Right? I mean, I know so many people who will not take HRT because they're like, it's going to cause breast cancer. And I'm like, but drinking alcohol is just as much of a risk.
If not a little bit more.
And they don't believe it.
Because they don't want to believe
They don't
it.
want to believe it. Yes, because we do
No.
love our wine. It's true. But but it's these kind of things that once you know them, you can't unknow it. And then it starts percolating in the back of your brain. And then you
might have the opportunity to really understand the disconnect.
Right.
That I'll still have my wine every night, and that I'm okay with that risk, but I'm not willing to take this risk that's going to protect me in other
It's
ways.
about you
It's
making your own choices.
So, and that's the conversation that's not happening with breast cancer survivors. So family history HRT has never been shown to increase the risk. Now, if you're a BRCA carrier, that's a whole
Yes.
different discussion. If you
Right.
have a genetic,
Right.
thing,
And
and they're
when people-
recommending, if someone's not recommending having your ovaries out
Mhm.
with whatever gene you have, yet they won't give you HRT.
Mhm.
I'm like, they let you hang on to your much higher estrogen in your
Right.
natural reproductive cycles, yet they're
Mhm.
going to take it away in your postmenopausal years.
Right.
Just think about it. It doesn't make sense.
I know. I've heard all of you in your menopause talk about the replacement of insulin or the other things that we go through medically.
Thyroid, yeah.
Right.
That is just normal. Of
Right.
course,
You would not treat it.
you would not ever treat that. And so why is this looked at something that's unnatural and that kind of thing when we're just replacing back, just like we would with anything else that happens
You
to
tell
us?
me.
So you've got these tests that you'll do if somebody is past that 10-year window. If somebody is just entering menopause, are there tests they have to do?
So we don't do, the menopause, we don't do a lot of hormone testing. Perimenopause is a zone of hormonal chaos. And if you're in it, I hear you, girl. And so you cannot use a one-time blood, urine, or saliva test, even a 3-day blood, urine, saliva test. We're really good with a one-time blood test to diagnose postmenopause, but perimenopause, it's not super diagnostic. So there's something called the green score, the green scale. It was developed in 2008. No one actually uses it, but it has been validated to be able to define if the constellation of symptoms that you're having might be related to perimenopause.
Okay.
So when those patients come in, I'm doing a ton of blood work, just not hormones. I'm checking inflammation markers, the CBC, all their basic blood tests, but I'm adding in, do they have their high sensitivity C-reactive protein? We're checking iron levels. I'm getting a vitamin D. I want to make sure I'm not missing something that these deficiencies could be also look a lot like
Right.
perimenopause.
Yeah, because I had to have my thyroid checked first.
Do a full thyroid panel.
Yeah. But let's say that you don't have periods, you're super skinny or whatever, or you have an IUD and you don't have periods. How do you know?
Or an ablation or something like that.
Right. So
Right,
you don't
right.
have periods for whatever medical
for whatever
reason,
reason.
or,
Yeah.
how, if you don't have that period to hang on to. So for those patients, they're the ones I'm going to get some hormones on to see, are
Okay.
they postmenopausal?
I know there's going to be people that are going to ask about testosterone.
Uh-huh.
And I understand that you have to get your levels checked. Why do you have to have tests for testosterone
So-
but not for estrogen?
So testosterone is more steady state in the female.
Okay.
Where estrogen and testosterone does fluctuate a little bit, but nothing like estrogen and progesterone. Testosterone, because we make some in our ovaries and some through the adrenal pathway, we have a more steady state. It's really easy to overshoot a female for her testosterone levels. So we do want to get a baseline
Okay.
and then kind of monitor, especially if she's symptomatic, like hair growth
Yeah.
or losing hair, all the things that testosterone can do if you go too high.
Right.
And so we do tend to monitor that one a little closer because we can predict that one a little bit better.
Okay.
Can
That's
I-
a great question.
Yeah, go ahead.
Sorry. Just speaking about that though, because you mentioned hair, and we had an amazing discussion about how it impacts your hair to begin with.
Mhm.
But if I could, since we're talking about trying to recognize the symptoms of or how we move into it, regarding the hair and the thinning and the concerns of just textural changes, is there a point where you can start to recognize and say something's a little off, and I'm going to get ahead of this now, and try to address the things before I go, now my hair's really thin and it's breaking everywhere. Now what do I do?
Yeah. So one of the things, so there's male pattern type, hair loss, and there's female pattern type hair loss. So male pattern type hair loss can happen to females for sure. And it's usually temporal balding. So they'll notice they're getting thinner, here at the temples. Also at the same time, if they're that high to cause this, you're all of a sudden you're getting the chin hairs and more hair growth where you don't want it. Female pattern, which is more age related, we do lose, the quality and quantity of our hair follicles as we age. The part gets whiter is what we see. That's less as hormonally driven. And so when my patients come in and they're immediately, something's different with my hair, I don't know what's going on, we start looking at the pattern of where they're losing it. And so we start talking immediately about, are you iron deficient? We look for nutrition deficiencies. We start talking about spironolactone or, anti-age. So if it's male pattern, there's medication we can do to try to block those testosterone receptors specifically in the hair and the skin. We can, minoxidil works for everybody. Dermatologists love it. It's over the counter, so I did topical minoxidil for years. The hair math got to be a lot for me because I color it and it had to be clean and what day am I going to be done? So then one of my derm friends was like, just take it orally. And I was like, oh, that would be a lot easier. So now I just pop a minoxidil every night.
Yeah.
You know, no side effects for me. So.
That's great.
Some people are probably wondering like why a guy isn't here talking anyway.
I think it's so important.
And it's not just about hair. That's obviously my background. But as a husband to this lady over here who has self-prescribed herself going through this change and this challenge right now, there's a lot of symptoms that happen clearly. So as a guy, what do I need to know? Like, how do I best support her going through these things?
So just like where I sit on this side of the desk, you know, validate. Absolutely. Like, I hear you, I see you, you know, it's not her fault. Right. Imagine, you know, if at 50, at the average age of 51, if all male testicles just shriveled up and stopped working, if you ran out of your spermatozoa factory and that was it, and you had no more testosterone production.
And it caused a bunch of other things, like it hurt to have sex.
Well, it would.
And
it would. You would. Your mental health would
sneezed.
change. Your, you know, your muscle mass would dramatically decrease. Right. That's what's happening to her. And so getting your head wrapped around it is the first step of all of these things could happen. And like, all right, let's figure this out together. If she woke up tomorrow with whatever medical diagnosis, I know you would be there for her, you know, and then realizing society's got a while to catch up. But sadly, you know, when we look at the mental health picture, 1 in 5 women is on an antidepressant at the age of 40. And then it goes up to 25% after the age of 60.
Yeah.
How much better would it be for her mental health if immediately it was validated? Immediately. And that's not your fault.
Yeah.
Society hasn't caught up with this yet in the realization. You want to stay married.
Yeah.
Obviously.
100%.
You know.
Yeah.
I mean, most
And-
women don't even know what menopause is.
exactly.
We can't expect all the men in our lives to know as well.
It makes perfect sense though, because it's so quick for like as a guy for us to discount it. But if I mean like our testosterone lowers, not the same thing, but
It's about 1% a year, your andropause.
yeah. And so if you've got like I've always had low testosterone levels just my whole life. And so I know like it makes a huge difference in me. So why would it seem weird to think that if hormones are changing in your, you know, in your wife or girlfriend or whatever, that wouldn't also affect all the other things.
Right.
Yeah.
And I would complain incessantly about it if I wasn't able to take something for it. I would be off the wall.
Right. So she goes in and 80% of she only has a 1 in 10 chance of a practitioner recognizing that it's perimenopause.
So you just made me think of something. On your cruise, we did the PauseLife Retreat, which was wonderful. I understand you're going to do it again. I would love for you to talk a little bit about the PauseLife Retreat.
Over a year ago, when the beauty influencers, the babies, you know, were going on all these trips to Dubai and all these, you know, fabulous influencer trips, my followers were like, hey, where's the menopause trip? You know? So I was like, that would be fun. Let's do a menopause trip. So it was kind of a tongue in cheek. And then it kind of turned into, let's do a menopause retreat. Like, let's bring all these people together and have these great discussions about the future of menopause care and what you can do if you have X condition or Y condition. And so I gathered up the Menopause, a few members, and was like, hey, y'all want to come on a cruise out of Galveston? Sure. And then we opened it up to the public. We had 100 spots. We filled almost immediately. And it was one of the most life-changing experiences.
So
and
good.
you got to go.
Yeah.
Of my life. And so the minute it was over, we're literally walking off the ship. I'm dragging the luggage and everything. And I'm like, well, we got to do this again, but no more cruises. We had seasickness. There was a rogue wave. Wasn't the right venue for everyone. I'm like, we should just do this on land. So we are going to host the next menopause retreat, bigger and better. We're hoping for 3,000 attendees.
Yeah.
In Galveston, so very inexpensive in January, low season. I wanted something affordable. I'm hoping to price the tickets around $50 a person, so that everyone can come.
Yeah. On the cruise, you gave a talk about what you would tell your 35-year-old self. I would really love, because it was a moving conversation. I would love you to kind of talk to us about that a little bit.
So it's one of the conversations I try to have with my kids, and it's, you know, now that I know what I know, after all of this research and writing a book, and, you know, what would I go back and do differently? What would I tell 35-year-old Mary Claire? And I would say, number one, nutrition over calories. I was a cardio queen. I literally moved my body and ate to be thin. I equated thinness with health. I thought nothing of the quality of my food. And I went back to school in my late 40s to learn about nutrition at Tulane, and I got certified in culinary medicine. And like, that information was critical. Like, knowing that kind of stuff has totally changed my approach. So nutrition is more important than calories. and strong over skinny. I only exercised to be thin. I ran marathons to be thin and hang out with my girlfriends. And, you know, like, why weren't we in the gym lifting weights?
Yeah.
You know, I didn't understand how important retaining muscle mass or building muscle is with age, and how that's going to determine the course of whether or not we get diabetes,
Yeah.
whether or not we end up in a nursing home, whether or not we can get off the toilet without a bar on the side.
Yeah.
Like,
Yeah.
all of that was so important. And we reach our natural muscle mass, you know, without age starting to chip away at it at 30.
Yeah.
And
Yeah.
so, you know, I wasn't eating adequate protein. I wasn't doing the resistance training. I was only doing cardio, really.
Right.
And so that I would totally do that differently again. I would have learned about menopause.
Right.
Yeah.
You know, educated myself about the importance of menopause, what it really means outside of just hot flashes and your period stopping and not being able to have a baby. You know, like, it is 1,000 times more than that. And I would have looked at aging as a privilege. I hated aging. I hated menopause, you know, old people, you know, and like, now I'm an old person. And so I'm like, wait a minute, I'm living my best life right now.
Yeah.
Like, I'm more successful. I touch more people. I've changed more lives than I ever did doing pap smears, which I loved my job. But I was a terrible menopause provider at 35. I didn't know what I didn't know. And now I'm spending the rest of my life trying to make up for that.
Yeah. Which
Love
you are doing.
Yeah. Which you
In
are definitely
spades.
doing.
Yeah.
So,
yeah.
pretty
To
amazing.
put it lightly.
Yeah.
We're so lucky to have you
Yes.
and everyone out now
Yeah.
on social media.
What a great conversation.
Yes.
Thank you
Yes,
so
been.
Yeah.
much.
Thank you for
Thanks
taking
for
the
having
time.
me.
Yeah. I have 1,000 more questions for my viewers. So we'll have to do I have to have
Yes!
you on my channel as a separate
Absolutely.
thing, and when your next book comes out. or
Absolutely.
Whenever. I just want to thank Dr. Haver so much for taking the time to come and speak with us, to share her knowledge with everyone, and just for being out here and changing the conversation about menopause so that more people can get the help that they need to be the healthiest and happiest they can be going forward. I hope that some of the information that she shared in this video will be able to help you in your menopause journey. If you want to pick up the new book, I'll put a link in the description box below the video, along with the weighted vest that she uses and anything else that we discussed during the video, her other book, The Galveston Diet, and of course, all the other resources that we mentioned, all the other doctors that I follow on social, all the other telehealth, in case you're looking for a doctor and there isn't anyone in your area, the Menopause Society. All the links will be in the information box below the video for you. So I hope you found the video helpful and informative. If you did, give it a like and don't forget to subscribe to my channel. As always, I thank you so much for your time. I really appreciate you watching. Have a great day, and I will see you in the next video. Take care, everybody. Bye-bye.